Right now, in the medicine cabinet of 1 in 4 dementia patients in America, there is a pill. Their doctor prescribed it. Their family trusts it. And every single night, it is swallowed. It is silently accelerating the very condition it was never designed to treat. This is not a fringe drug. This is not some experimental compound from a clinical trial nobody has heard of. This is one of the most commonly prescribed classes of medication in the country, and it is being handed to the most vulnerable patients in the healthcare system. Patients whose brains are already fighting for every memory, every moment of clarity, every flicker of recognition when a loved one walks into the room. A landmark study published in January 2026 exposed something that should have changed prescribing practices overnight. It didn't. And if someone you love has dementia, or if you are caring for someone who does, you need to hear what these researchers found. Because by the end of this video, you will know exactly which pill I am talking about, what it does inside the aging brain, why doctors keep prescribing it despite the evidence, and the one conversation you can have this week that could change everything. I am Dr. Richard James. I have spent over 3 decades studying how medications affect the aging body. And what I am about to share with you today is something I believe every single family with a loved one over 60 needs to hear. In the next 18 minutes, I am going to walk you through what this drug does to the brain after 60, what the January 2026 JAMA study, backed by UCLA and the National Institutes of Health, actually found, and the precise steps you should take starting tonight. This is not a niche problem. This is not a rare side effect buried in the fine print. We are talking about a class of medication prescribed to millions of older Americans, given to people whose brains are already under siege from cognitive decline. And the most troubling part is not the drug itself. It is the reason doctors keep prescribing it, despite knowing what the research says. That answer is coming, and it is not what you expect. The pill I am talking about belongs to a class of drugs called benzodiazepines. You might know them by their brand names: Valium, Xanax, Ativan, Klonopin, Restoril. These are household names. Chances are you have seen at least one of them on a prescription bottle in your own home or in the home of someone you love. Benzodiazepines were originally designed for short-term relief of severe anxiety and insomnia. Short-term, that is the critical word. They work by enhancing the activity of a brain chemical called GABA, gamma-aminobutyric acid, which calms neural activity and produces sedation. For a young, healthy adult dealing with a short-lived crisis, a few days of a benzodiazepine under medical supervision can be appropriate. But here is the part that should stop you cold. These drugs were approved decades ago, when short-term meant days, maybe 2 weeks. The clinical guidelines have always been clear on this, and yet somehow, benzodiazepines became one of the most chronically prescribed drug classes in geriatric medicine. How did that happen? How did a short-term sedative end up on the permanent medication list of people with dementia? That is not how they are being used. According to the January 2026 JAMA study, led by Dr. John Maffei at the David Geffen School of Medicine at UCLA and funded by the National Institute on Aging, approximately 1 in 4 Medicare beneficiaries diagnosed with dementia were prescribed potentially inappropriate CNS active medications. Benzodiazepines were among the most commonly prescribed drugs in that category. Think about that number for a moment. 25%. That is not a rounding error. That is a systemic pattern. And these are not patients who were given the medication for a few days after a crisis. The study analyzed prescribing data from 2013 to 2021 across 4,842 older adults linked to Medicare claims. In many cases, these medications were prescribed for months, in some cases, for years. The researchers found that while overall prescribing did decline from about 20% to 16% across all Medicare beneficiaries during the study period, patients with dementia continued to receive these drugs at rates far higher than those with normal cognition. If you have a loved one with dementia, I need you to go look at their medication list, tonight, this week. Because what this drug does inside an aging brain is something every family deserves to understand. But the most alarming finding in this study is not the number of prescriptions. It is what these medications do to the patients who take them, and that is coming. Now you know what they are. But here is where the science takes a turn that genuinely alarmed the researchers who conducted this study. Here is something most doctors never take the time to explain. After 60, your body does not process medications the way it used to. The liver enzymes responsible for breaking down benzodiazepines slow down significantly. Your kidneys filter waste and drug metabolites more slowly. And the blood-brain barrier, the protective shield between your bloodstream and your brain tissue, becomes more permeable with age. Why does this matter so much? Because benzodiazepines are not water-soluble drugs that flush through your system quickly. They are lipophilic. That means they dissolve in fat and accumulate in fatty tissue. And after 60, body composition shifts. You carry more fat and less muscle. The drug has more places to lodge and fewer pathways to get cleared out. What does that mean in plain language? It means the same dose of Valium that cleared your system in 12 hours when you were 40 may now linger in your brain for 2 or even 3 days. The half-life of some benzodiazepines can double or even triple in older adults. And that number is not theoretical. That is pharmacology. That is measured, documented, and published. Now picture this. A patient takes their pill on Monday night to help with agitation. By Wednesday morning, the drug is still active in their brain. Their family visits and notices they seem more confused than usual, a little more unsteady on their feet. They chalk it up to the dementia getting worse. And on Wednesday night, the patient takes another dose. They are now stacking sedation on top of sedation, on top of a brain that is already compromised by dementia. I see this pattern constantly. The family comes in and says, "She was doing okay for a while, and then she just declined so fast." And when I look at the medication list, there it is. A benzodiazepine that was prescribed months ago, refilled automatically, never questioned. This is not just a theoretical risk. Research published in the journal Maturitas confirmed through systematic review that benzodiazepine exposure is consistently associated with a higher risk of falls in older adults. A separate population-based study found that long-acting benzodiazepines more than doubled the risk of falls and fall fractures in seniors, with an odds ratio of 2.16. Falls are the leading cause of injury-related hospitalization and death in adults over 65. And in a patient with dementia, someone who may already be unsteady, confused, and unable to report symptoms, a single fall can mean a broken hip, a hospital stay, and a decline they never recover from. So the mechanism is clear. The drug lingers. The brain absorbs more of it. The damage compounds. But here is the question that the JAMA researchers set out to answer, and what they found should change how every doctor in this country approaches prescribing for older patients. In a moment, I will give you the exact steps to take, starting tonight. The study was published in JAMA on January 12, 2026. Researchers from UCLA and the National Institutes of Health examined prescribing patterns of potentially inappropriate CNS active medications across thousands of Medicare beneficiaries aged 65 and older with varying levels of cognitive function. And what they found was not subtle. Despite years of clinical guidelines warning against it, despite the American Geriatrics Society explicitly listing all benzodiazepines on the 2023 Beers criteria as medications to avoid in older adults due to risk of cognitive impairment, delirium, falls, and fractures, roughly 1 in 4 patients with dementia were still being prescribed these drugs. Not briefly, not for acute crises, for extended periods. And over 2 out of 3 of those prescriptions lacked a documented clinical indication. That means the medical record did not even contain a clear reason for the prescription. Let that sink in for a moment. The study also broke down prescribing by cognitive status. Among older adults with normal cognition, 17% received these medications. Among those with cognitive impairment but no dementia diagnosis, nearly 22%. And among patients with confirmed dementia, the group most vulnerable to every single side effect, 25%. Do you see the pattern? The more fragile the brain, the more likely the prescription. That is the opposite of what the guidelines recommend. The AGS Beers criteria, the gold standard reference for safe prescribing in older adults, gives benzodiazepines a strong recommendation to avoid for everyone over 65. Not a suggestion, not a caution, a strong avoid. The criteria specifically warn of increased risk for cognitive impairment, delirium, falls, fractures, and motor vehicle crashes. And yet, 25% of the most vulnerable patients in the country are receiving them anyway. Now, I need you to understand something important here. This is not about bad doctors. I want to be very clear about that. This is about a system that is overwhelmed, understaffed, and reaching for the fastest tool available when a patient with dementia is agitated at 2 in the morning, unable to sleep, pacing the halls of a memory care facility. The pill is easier than the protocol, faster than the behavioral intervention, and in the moment, it works. The patient quiets down, the night shift moves on, but the cost of that quiet is invisible. It shows up weeks later, months later, as accelerated cognitive decline, as a fall in the bathroom, as a hospitalization that might have been prevented. And the family never connects the dots. They see the decline and assume it is just the disease progressing naturally. But how much of that progression was the disease, and how much was the drug? You might be wondering why your doctor never mentioned this. There is a reason. The systemic pressure to manage behavioral symptoms quickly, especially in understaffed nursing homes and memory care facilities, often overrides the guideline recommendations. The study's senior author, Dr. John Maffei, noted that while the overall decline in prescribing was encouraging, the persistently high rates among cognitively impaired patients point to a gap between evidence and practice that has not been closed. It is not malice. It is a system that has not caught up with the science. So now you understand the drug, you understand the mechanism, and you understand why the system keeps failing the people it is supposed to protect. The only question left is, what do you actually do about it? And I want to give you a very specific answer. Now I know what some of you are thinking, but my mother was so agitated at night. The pill was the only thing that helped her sleep. And I hear you. I understand that. Managing dementia is one of the hardest things a family can face. The sleepless nights, the confusion, the fear in their eyes. Nobody is dismissing that. But here is what the research consistently shows. The short-term calm that benzodiazepines provide comes at a long-term cost that is often invisible until it is too late. The patient seems stable. The medication seems to be working. But underneath that apparent stability, the drug is compounding sedation in a brain that cannot afford any more fog. And there are alternatives, safer ones, non-pharmacological interventions, structured daily activities, consistent sleep routines, light therapy, environmental modifications like reducing noise and nighttime stimulation have shown real benefit for managing dementia-related agitation. And when medication is truly necessary, there are options that carry fewer cognitive risks than benzodiazepines. The conversation with the prescribing doctor is where that starts. I am not telling you to throw the pills away tonight. I am telling you to have a specific conversation with the prescribing doctor this week. So here is exactly what I want you to do. This is the protocol I give to families in my practice, and I want you to follow it precisely. I am going to give you 4 steps. Each one is specific. Each one is something you can act on this week. Step 1. Tonight, go look at the medication list. Every medication. I want you to look for these names. Diazepam, also called Valium. Alprazolam, also called Xanax. Lorazepam, also called Ativan. Clonazepam, also called Klonopin. Temazepam, also called Restoril. Check for both the brand name and the generic. If you are not sure, take a photo of every pill bottle and bring it to the next doctor visit. If any of those names appear on that list, move to Step 2. Step 2. Call the prescribing doctor this week. Not next month. Not at the next scheduled appointment in 3 months. This week. And say exactly this. I would like to discuss whether this benzodiazepine is still the safest option, given the January 2026 JAMA findings on CNS active medication use in dementia patients. That one sentence changes the conversation. It tells the doctor you are informed. It opens the door to a medication review. And most importantly, it puts the question on the record. Step 3. This is critical. Do not stop the medication on your own. I cannot stress this enough. Benzodiazepine withdrawal can be dangerous, especially in older adults. Seizures, severe rebound anxiety, confusion, delirium. These are real risks of abrupt discontinuation. Any change must be supervised by a physician and tapered gradually over weeks or months. This is about having the right conversation, not making a unilateral decision. Step 4. Ask about alternatives. Ask specifically about non-pharmacological strategies for managing agitation and sleep disturbance. Ask whether a safer medication class might be appropriate for your loved one's specific situation. Write the questions down before the appointment so you do not forget. You are your loved one's advocate. Nobody else is going to ask these questions for them. Here is the number from this study that I believe should end the debate. Over 2 out of 3 patients receiving these prescriptions had no documented clinical indication for the drug. That means the majority of these prescriptions cannot even be justified by the patient's own medical record. That is the finding that should keep every prescriber in this country awake at night. You now have the drug names, you have the study reference, you have the exact language to use with the doctor, and you have a timeline. This week. Your loved one's brain is still in this fight. The memories are still there, underneath the fog. And now you know something that could slow the damage, maybe even help stop it from getting worse. If this video helped you understand something that nobody had explained before, I need you to do one thing. Send it to one person, one family member, one friend, one caregiver who has a loved one with dementia. You might never know it, but you could be the reason someone they love gets a safer night's sleep. I am Dr. Richard James. Subscribe, because next week I am covering another medication that millions of seniors are taking right now, one that most families have never thought to question. Take care of yourself tonight, and take care of the people who cannot protect themselves. I will see you in the next one.